Thank you. And now and I thank each of you for this interesting panel. Mr. Deal, why don't you begin with your 5 minutes of questioning?
Thank you, and thank you to all of you for waiting this long to be here for this. Obviously, as you know, transparency is an issue that's of importance to me. You know, almost every other thing in life, we know what the cost of it is. Healthcare, we don't know. We don't know the results. We don't know what the effectiveness is of hospitals or of individual practitioners within the medical community. So transparency on all of those fronts, I think, is an important ingredient. For those who would say that just because people don't pay for things out of their pocket, that doesn't mean that it means that they're not concerned about the cost. I would like for them to have been in conversations where family members, when they have a relative who's been transported to the hospital, the one thing that they always complain about is the $700 ambulance fee charged to transport their loved one for less than a mile. Now, you can believe they focus in on those kind of things, and they want to know why public programs are paying what they consider to be exorbitant prices. The trouble is they don't know those kind of things in their health care in general. So I appreciate the testimony that we've received. I think, Mr. Bachman, you almost sounded like I wrote your speech for you there. I think I agreed with virtually everything that you said. How do we deal, though, with this question of disclosure of pricing, price transparency? How do we get a handle on that? How do we best accomplish that objective?
Well, there are a number of areas. First, I'd like to say that the transparency that I believe is appropriate goes beyond even what's been suggested in your bill here. I think transparency on service costs, how well you're being treated, the time in the waiting room, bedside manner, things that are not clinical but are more service-oriented is important disclosure. The way we get at it, I think, is a couple things. One of the issues that was not mentioned in the earlier panel, I didn't mention it and I hadn't heard the words here, is the Internet. We're now seeing a tremendous growth in what's called Web 2.0. People talking to other people about their experiences with providers and physicians. So we're having people talking to other people that's creating a disclosure. That's one thing. The second thing, there's a growing interest. It's slow, but there are vendors out there that are beginning to encourage providers to create package pricing so that you have one price. How much is it going to cost to treat my diabetes for the next 12 months? And that way, if there's a package pricing, it's sort of a combination of the old capitation rates and fee-for-service mainly, but it's where the provider says, I can take care of you for this amount of money, and the services don't have to fall into the traditional CPT codes or ICD-9 or DRGs. It's what the hospital can show and demonstrate will work best, and employers are buying into that, but that is only at the beginning stages. The third area that's going to push that is what is actually happening. I think your chart showed a third world country. Well, that is actually happening today in most of the areas like Singapore and other countries that are getting medical travel, medical tourism, if you will, and hundreds of thousands of people are going across the ocean in order to get services that are 1/10 the cost at better hospitals, more modern hospitals, many of them managed by the major brand name facilities in this country, and they're being treated by doctors that are trained in the United States as well. So, and they're being approved by quality organizations that approve quality hospitals in the United States as well. So I think there's a gathering of a number of forces to push this in the right direction.
Dr. Herslinger, we heard Dr. Ginsburg talk about pricing on a per episode basis, and I think we're hearing a lot of talk about how do we refigure compensation for services and episode-based. You called it package pricing. I presume it's sort of the same concept. Dr. Herslinger, how as we, I think, will certainly look at that issue very closely because it appears to be coming from a variety of sources, how do we make that kind of pricing information available, not just the fact that the services are being bundled, but the costs associated with that bundling?
If you're asking about the administrative model,
Yes,
is
you
that
you
correct?
suggested something similar to the SEC, I think.
Yes, well, the most transparent market in the world is the financial market, and it's led to what's called efficiency in the market. It doesn't mean that it's perfect. We know it's not perfect, but it is the most transparent market. There are countries all over the world that are adopting the SEC model, and the reason they're adopting it for their own financial markets is that that model creates the best transparency. The SEC model has two parts. One is the iron fist, that is the SEC. SEC has tremendous enforcement power. The Velvet Glove is an organization that's now called the FASB, and that is a group of stakeholders. They're experts in measurements, accountants, people from the business community, CFOs of companies, and consumers. And that Velvet Glove is the one that actually determines what should be measured. Companies have to comply with these standards. If they don't, the iron fist of the SEC comes along. It's been a fantastic model that countries all over the world emulate. We should use it for healthcare. It works.
Madam Chairman, I know my time is out, but I would ask unanimous consent to include a letter from the executive branch of the state of South Carolina supporting the concept of transparency.
Without objection, so ordered. And now I allow myself 5 minutes to ask my questions too. And as you may have noticed, the buzzer rang, and we do have votes on the floor at the same time. We can wrap this up, but we won't be able to go to a second round, which is unfortunate. Dr. Ginsburg, you testified that one of the key barriers to making price transparency work is the lack of transparency on quality of care. It's clear that hospitals' prices may be low because they're understaffed, or they use cheap medical devices and so forth. As you have pointed out, consumers may assume that high-price providers are high-quality providers, an assumption that may have no basis in fact. So where do we stand? And this is a large question for a short amount of time. In producing information on provider quality that could be accurate and usable by consumers, if we require quality transparency tomorrow, would there be any standard? Would there be information available? And what should we be doing now or taking some steps in this direction as we seek to reform healthcare?
Sure. Well, in the case of hospitals, we do have some data.
You may turn on your...
Yeah, I think it's on. In the case
Okay.
of hospitals, we do have some quality data. I think a lot has been accomplished when the Medicare program offered an incentive to hospitals. If you would report on these measures, we'll pay you a little bit more. Virtually all the hospitals have done this. I don't think consumers are making much use of it now. It's pretty fragmented. But when it comes to the hospitals themselves, everything that they are reporting to Medicare or to the Joint Commission, they are focusing on improving. And the example we had on the first panel about when physicians and hospital leaders see low quality in their practice, they're very motivated to do something with it. So I think in the next few years, we can get a lot of mileage out of quality reporting and transparency just from the provider reaction to it, even if consumers using it, I think, is many years down the road. As far as price transparency, I don't have, problems with it in general. I think there's potential for it, definitely down the road. And my main caution was that we shouldn't get too wound up in how much it will accomplish in the short run. There are a lot of other things that have to be done to improve our healthcare system.
Thank you. I know there's more follow-up because I'm also interested in how consumers can benefit by this as they make their decisions and out into the community settings, clinics and so forth, which is where a lot of decisions get made. But I want to turn, because there are just a couple minutes left, to you, Ms. Archer. A key feature that consumers are interested in for most products is the warranty or guarantee. They want to know if something goes wrong, there's a way to get the problem resolved. In the health insurance market, we've heard story after story about denial of claims. some very egregious appeals rights in place on paper, but really not very effective. Problem is, consumers don't even know about their rights before they purchase health insurance. Can you describe what information about appeals and grievance procedures should be there, available to consumers in language they could understand? And do you think that more transparency on appeals and grievance procedures is the way we should go in terms of ensuring that insurers will do the right thing?
Yeah, thank you for that question. Actually, we have a big lesson to learn from Medicare on this front. The way Medicare works, it's data about what it covers and under what circumstances are all on the web. And if a doctor performs a procedure that's medically unreasonable or unnecessary and delivers it, it's the doctor who actually gets stuck holding the bill, because the doctor can go online and find out in advance what is covered. If the doctor thinks it's really necessary, the doctor can tell the patient, yes, I think you should have it, but Medicare won't pay for it, and have the patient sign in writing that he or she is willing to pay privately. If Medicare doesn't pay, the patient can then appeal and has gotten a written notice about it. So the patient isn't stuck with a lot of bills from insurer denials that often patients in the private insurance marketplace face, because no one knows, including the doctor in many instances, ahead of time whether the insurer is going to cover the claim or not. So I think that model is a model that could easily be adopted to the under 65 population to help patients in terms of protections financially if a service a doctor wants to give them is.
Could this be accepted by the private sector?
It should be accepted by the private sector, because it's the fairest way to protect the patient from receiving medically unreasonable and unnecessary care from a doctor. Why should the patient receive the service if it really is unnecessary? Everybody's on notice. That's what the insurer thinks. If the insurer is wrong, if the outside world says the insurer is wrong, the insurer is going to come under attack, under public scrutiny, and will have to change its practices. If it's appropriate and what the doctor is doing is inappropriate, then the patient shouldn't be absorbing the cost of the care.
I wish I had time to ask others what you think, but you believe, Ms. Archer, that Medicare does provide at least some kind of model for doing this.
An excellent model. And then I think, just to your second question, I think the denial and grievance information needs to be public so that, again, it can be scrutinized and people can understand what insurers are doing.
Thank you again very much, all of you. This is abrupt because of our call to the floor, and I appreciate very much your testimony. The reason the microphone is needed is that this is part of our record now, and we appreciate that as I say, we go about making some important decisions.
Thank you.
So nice to see you again.